All right, thank you, Letitia and HHS. Next up, I'd like to invite, coming from Marin County, the Public Health Officer, Dr. Matthew Willis.
Thank you. So you've heard some from the federal perspective. I'm going to offer the local perspective on this. I am a local public health officer. I work in Marin County. We've been grappling with the opioid epidemic now for the last 4 years as a public health priority. I'm also an internal medicine doctor and have been part of the problem. My experience with the opioid epidemic, and I think all of us in some way are living this epidemic now because it's so prevalent, began about 20 years ago when I was in medical school and was beginning to be taught in that context to make sure that for every single patient we were soliciting any possible experience of pain they may be having on every visit. And combined with that was this other message that was intended to be a reassuring message to us as physicians, which is the good news is that there's a safe and effective and affordable remedy behind you on the shelf. There's opioids that you can easily prescribe to these patients. And over time, over about 20 years, that led to a history of overprescribing, frankly, among the medical community. And we're just beginning to now try to unbury ourselves from under this. So over that period between about 1999 to about 2010, we rendered an entire cohort of individuals addicted to opioids, partly because of primary care and normal allopathic medical practice. There are now efforts to try and reduce overprescribing, and one of the things I'll describe is our safe prescribing efforts. Since then, now as a primary care doctor, when I actually graduated from residency and became a physician in Marin County, I recognized that those patients who had been prescribed opioids may not be having the benefit in their lives that we had expected from that. And in fact, some of my patients had experienced overdoses themselves. I then moved into primary care, into public health. And as a public health officer, I ended up having a chance to look at this from a wider lens across the community and seeing the data that was available to us countywide and recognizing that opioid overdose were in fact, back in 2014 and remain so, the leading cause of accidental death in my county, with one accidental overdose to opioids every 2 weeks in Marin. And as we're seeing now in the nation, that translates, there's 72,000 deaths last year to opioids, which is 1 every 10 minutes. So by the time I'm done with this part of this presentation, there will have been two, if we average that out over time, 2 individuals who will have passed somewhere in the United States due to what I see as a preventable overdose event. So that's some of the context for my lens. So I have a very practical need for solutions. And I think my hope is that this hackathon will actually lead to solutions that we can implement at the local level in the short term, because we don't have time to wait. This was an interesting analysis that was done about 2 years ago that basically forecasted different scenarios for the opioid epidemic. The top trajectory there was, if we don't do anything differently, what can we expect in terms of the number of deaths we'd see over time? On the one axis, you have time down to 2025. On the other axis, you just have the number of deaths that we would expect. Modeling the current trajectory, obviously, this was done 2 years ago. We are actually on track. In fact, we're actually doing worse than even that worst case scenario that was projected 2 years ago. And that's partly because of the changing nature of the epidemic and the introduction of other agents like fentanyl and illicit opioids. What's important about this is that the most optimistic scenarios, those scenarios where we actually start seeing over time decreases in overdose deaths, make an assumption that we are making success and progress in multiple domains at once, so that we are actually achieving those safe prescribing guidelines more reliably each and every time we're prescribing opioids. That patients have opportunities to safely dispose of medications each and every time. That people who are addicted to opioids have access to treatment that they need. That naloxone, the medicine that can reverse an overdose when it occurs, is available in a timely way on site. That some of the stigma around addiction has been relieved. And it's only through a combination of all those strategies occurring simultaneously and in parallel can we actually expect to see this kind of success even over the next few years. This was, you may have seen just the more recent CDC report, 72,000 deaths in 2017. So despite all of our efforts, the epidemic actually continues to accelerate. At the height of the AIDS epidemic, any idea how many deaths? We had about 55,000 deaths. I think about 1995 was about the peak. So this is worse than the biggest plague that we've really experienced as a nation, and it's continuing to accelerate. This was an analysis I want to share with you that was done, published in the New York Times recently. Dr. Dan Ciccarone, who's an addiction specialist up at UCSF in San Francisco, partnered with the investigative journalists at New York Times and basically asked 30 experts in the field at the national level. So these are people who were in social services and law enforcement and public health, in other domains of civic service. If they had $100 billion to spend, where would they invest it to address the opioid crisis? And and this was the consensus, this mosaic. It was sort of like the relative attribution, or the amount that each would sort of allocate, averaged. And what you see is about half was dedicated to treatment, about a quarter was dedicated to reducing demand for opioids through community development and other strategies. And then for the remaining quarter, we're divided between harm reduction, so that's the naloxone, which I'll talk a little bit more about, the medicine that can reverse an overdose when it occurs, and then reducing supply through precision monitoring and law enforcement efforts. So the point is that there was consensus among the experts that we need to be working in multiple domains at once to address this issue. And what we don't have right now, and I think it was alluded to by Health and Human Services, is infrastructure, even data infrastructure, to integrate these strategies that need to be incorporated at the same time. None of these will be sufficient in and of themselves, but all of them will contribute in some way to the solution, even if they're done individually. Obviously more effective if we're able to integrate our strategies in a coherent fashion. And one of the jelly beans need to be together in the jar, right? So this is suggests that we need a collective approach. I had a chance to be in Atlanta in 2016 when President Obama was present at the National Drug Abuse and Heroin Summit. And basically his call to action was we need an all-hands-on-deck approach that says all of us are working together in order to address this problem. And then on a more academic side, the Institute for Healthcare Improvement that's done a lot of interesting work on this, did an analysis in 2016, and their conclusion was the epidemic will continue to worsen in the absence of coordinated and collaborative community-wide approaches, which essentially means that we need to be functioning differently. Coordinated and community-wide approaches means that we need to be outside of our silos that we normally engage in, right? So it's not healthcare, right? And what I've observed is that our hospitals like to sort of try and develop their own solutions to this. Our law enforcement people like to have their own idea of how they want to approach this. What we need to make sure is that we're actually having those conversations across those sectors. One way that we're doing that in California to have these integrated community-wide conversations, and I think this is important for you as participants, when we think about the implementation of the tools you may develop, you have allies in the field right now who are eager for whatever tools you may develop, and they are coalitions across the state that are designed at the local level and is part of the California Opioid Safety Network. So if you're imagining your sort of user, this is one potential ally for you. Most California counties have opioid safety coalitions that are functioning at the local level that integrate educators, law enforcement partners, elected officials, hospitals, healthcare systems, because of the complexity of this and the fact that we need to make sure that we're actually working at the local level. It's local solutions, as much as the federal and statewide response is important. Ultimately, it has to be implementable at the local level because that's where people actually live. This is what the coalitions look like. This is just sort of a graphic that represents the diversity of stakeholders at the local level that come together to address this. In Marin County, we have a coalition called RX Safe Marin. You'll hear from April Rivero later, who's from Contra Costa, and she's actively part of their coalition. These are the strategies that have been promoted through the coalitions. This is sort of the consensus within the state of California between the Department of Healthcare Services, Department of Public Health, local coalition leaders as the main domains of evidence-based strategies that you want to be promoting together. The first is to prevent new addictions, right? So we need to stop the bleed, and that remains an important strategy. In fact, because opioids are so ubiquitous, even in prescribing, we are still generating people who are becoming newly addicted to opioids. So we need to make sure that we're addressing that side of the equation through safe prescribing efforts, drug disposal and take back, so making sure that when people have their medicine cabinets unused and unwanted medications, they have safe opportunities to dispose of them, and then working upstream with our youth in terms of educating people about the potential harms so that we're increasing awareness. The next domain is managing chronic pain safely. We recognize that many people who are struggling with opioid addiction and misuse and who are at risk of overdose are actually, as I mentioned, sort of been historically offered these treatments and are on very high doses of opioids that are now viewed as unsafe. And there's an alarming sort of heterogeneity in the way that's approached. Some doctors are like, I'm out. Like, I know that this is unsafe now, and I'm just not going to prescribe these, leaving patients high and dry. Others will say, well, this patient is secure and safe within this regimen. I don't see a problem. I'm going to leave them where they are and may even continue to increase if they take it from a functional standpoint. There's not a lot of consensus around how we manage this. One thing that's important, though, is that many of these patients are taking medicines for chronic pain, and we do not have good alternatives for the management of that pain. It's not enough to say you can't prescribe opioids. We need to say, and here's something else you can offer these people. That's a huge area that we're working on. Tapering from high doses and limiting unsafe combinations of medicines that contribute to opioid overdose risk, like benzodiazepines, which are sedatives for anxiety and sleep, as well as opioids. Many of the patients, if we look at the data, who actually overdose and die, it's more than just the opioid. There's often combinations of those drugs. Finally, treating addiction, or next is treating addiction. This is one of the most important gaps I think we all recognize in our system, is that we need better opportunities for people who are addicted to opioids to get into the treatment that they deserve and need. There is a remedy. There's a treatment. This is a treatable disorder. That's an important message, and we need to make sure people can get into treatment. Partly, reducing the stigma at the social level, I think, is an important part of that, and that's one of the state strategies. And then finally, for harm reduction, the last is stopping overdose deaths. So recognizing that people are at risk of overdose because of the other determinants. If someone is actually overdosing and you have naloxone on hand, which is the medicine that will reverse the overdose when it occurs, it can be as simple as a nasal spray, you can save that life. So downstream strategies to stop the overdose deaths, including needle exchange and naloxone. So those are the big strategies. I'm just going to quickly go through some of the data behind them. This is for preventing overdose risks. We know that when with 10 days of the initial prescription, you already have about a 15% chance that someone will be taking that medicine a year from now. So this is the idea that when you prescribe for broken ankles, for example, even just a few days of opioids, there's a risk that that person will be taking that opioid 1 year from now. That was not your intent as a prescriber, but that's what happens because of the nature of the medicines. For managing patients who are on very high doses, this describes the way in which there's a very dose-dependent risk of overdose, and that people who are taking, on the lower right there, taking very high doses of opioids on a daily basis are at much higher risk of having an overdose death. Treating, we want to make sure that people are having access to the ongoing treatment, not just a detox approach, but actually a maintenance approach, and that there's data that shows that people who are on maintenance on the lower right-hand side are having much lower risk of overdose deaths than people who are detoxed. Fortunately, on the upper left there, we're seeing that there's increases in the amount of opioids being, buprenorphine being prescribed. All right, and then this is fentanyl is coming in, and we're seeing because of fentanyl, we're needing to accelerate our progress around Narcan and naloxone. I'm going to go quickly to this is what our coalition looks like in Marin County. And the idea is obviously everyone, we need to bring our superpowers to the table, right? And so you all have a superpower that we need desperately, and it's been really not as present in our response in terms of tech solutions and data. I know I'm out of time. Am I out of time? All right, let me just go through. So at 1 o'clock, we're gonna have a conversation about, for those of you who are actually gonna be engaging in building data solutions, we'll have a conversation about what are the pain points for local actors. So this is, sort of our appeal at the local level. I asked all the coalitions what they would ask you, right? So I, mentioned that I'm coming down here to talk to you. And these are some of the statements, and I'll offer these at 1 o'clock. These are some of the statements that summarize what the physicians see as their biggest issues, what the patients see as their biggest issues right now, what the coalitions are seeing, pharmacists, policymakers, public health, and law enforcement. And I think these are really important because they're in the words of those who are on the front lines and describe sort of the pain points that we're experiencing. So prescription for today, courage, creativity, and hope. You need to bring a sense of humor and make sure that you bring your superpower. And we can do it. And this is my 7-year-old boy who's reminding us that it's not just for this generation, but it's for the next generation and on the work that we do together today. Thank you.